It's, remember, homework, guys, is to help you, okay? I'm not taking it up. I'm not grading it. If you don't do it, you're hurting yourself. And the last minute scrambling around trying to pull it up on your cell phone is not going to help you either. So who's ready to tell me about what thiazides do in relationship to blood glucose levels and how they do that? Who's ready? Don't be shy. We're no buzzer up here. I'm going to call them. Winter. What do they do?
It decreases the insulin sensitivity
Okay.
by inhibiting the glucose transport process
Okay.
in the intramuscular.
Okay, that's one. What is another thing that it does? What else do they do?
Impairs insulin secretion.
There you go. So we've got increasing resistance to insulin, we've got decreased glucose uptake, and we have decreased release of insulin. We've got three things that they postulate thiazides do. At the end of the day, it's important that I understand those processes, right? And I understand the pathophysiology behind that. And when you look at all the different drugs that we use to treat elevated blood glucose levels, it's really cool that many of them work in so many different ways. Some make insulin and glucose more attractive, kind of like someone who's, well, I hate to say this because I want you all to think I do this.
It's too
I
late
don't
now.
go, I know, ain't it true? I do not go to bars, okay? Let me just tell you, I don't like a place that has no windows. If there's no windows, there's a reason I don't need to be in there. That's my theory. I don't like being around a bunch of obnoxious, impaired people whatsoever. But you know how people who've had a few too many drinks, all of a sudden that person becomes quite attractive? You're like, hey, checking you out now. Okay? That's what some drugs do between insulin and glucose. They kind of make them a little more attractive to each other. So they decrease some of that resistance. Okay? Some drugs help us to take that glucose up a little bit better, maybe through the GI tract. Okay? So understanding how your drugs work is really important when you're doing your patient ed, isn't it? Okay? And that's my point I'm making about all this. Okay? So understanding that as a nurse, if I've got a patient that's getting thiazides, I don't care if they're diabetic or not. I still need to know that should be having some kind of trend with blood glucose levels. Maybe at least I'm looking at their AM labs every day. If they had a complete metabolic panel, I can at least look at the glucose levels, right? And kind of keep an eye on that. Because we know what happens to people who have chronically elevated blood glucose levels. It causes micro and macrovascular disease. And folks, we need our vessels to be intact. We don't need them to be diseased. Because then you have problems with your eye and your kidneys and every other organ in your body, don't we? Okay? So patho is important for you as a nurse to understand how does this affect my patient's outcomes, okay? And that's why when you see things like this, it'll click, it'll make sense to you, and then when you're taking care of your patient, you take better care of your patient. Because now you know how to educate them, okay? And I have to bring my water with me again. Hey, wait a minute, I already turned you on. Oh, man, you are being cantankerous today. We'll give it a second, it'll come back up. But any questions before this pulls back up? We'll get timed out on me. Any questions about some of the stuff we've gone over up until this point? Do yourself the favor of reviewing normal processes so that you can understand abnormal processes. Again, what I see with students who get confused about heart failure is because they don't understand where normal blood flow goes. If you understand how it goes normally, you'll understand what happens when that particular chamber backs up. Is that thing dying on me? You sure are buzzing awful loud this morning. Today's not the day. Just want you to know. Slowly waking up. There it goes ever so slowly. Maybe it'll last through at least module A. Okay, now, I told y'all there would be some rhythms on this test, okay? And there will be rhythms again on module E for sure. So if this is an area that you struggle with, you need to start working on overcoming that deficit, okay? There are so many resources electronically for you today that we did not have. And so there's really no excuse for you not to be looking and finding that information and challenging yourself to overcome those, okay? There will not be anything tricky. Okay, again, our exams mirror what your NCLEX is, and NCLEX isn't out to trick you. NCLEX is out to make sure you're competent. Okay, students have such a misconception about what a test question is. A faculty member doesn't sit down and write a test question in 5 minutes and sit up and get up and go. There's so much more to it than you can understand. A trick question isn't a statistically reliable and valid exam question. Therefore, it doesn't measure what it's supposed to measure. Therefore, there are no trick questions in nursing school. You think they are, but they are indeed not. They're there to discern, does this learner have the ability to prioritize and know what their immediate action should be, what are their expected findings, okay? That's what they do. So, I'm not gonna put anything on there that even a skilled, seasoned nurse is gonna sit there and stare at a few moments to figure out what the heck it is. Or that an electrophysiology cardiologist takes back the patient to the cath lab and say, I don't know what this is either, let's just figure it out this way. I'm not gonna do that to you. These will be very cut and dry, because that's what you're gonna see on NCLEX, okay? So, looking at these rhythms here, what's the top, well, it tells you, what's the top one? Okay, and I think when I taught ACLS, I finally realized what was causing people to stumble sometimes. Don't we all use, we all use the same alphabet, correct? Okay, but are my T's gonna look like Winter's T's? Are my W's gonna look like Janaea's? No, but yet they're both W's. They're both T's. When you're looking at an EKG tracing, just look, are the elements there, not necessarily what it looks like. Do you see an upright P wave? Do you see a corresponding QRS? Do not worry about whether it's a positive deflection, it's above the baseline, a negative deflection, it's below the baseline. It doesn't matter. It matters in other ways, but not in terms of, is it sinus? So do I have a P? Do I have a corresponding QRS? And then do I have a T wave? If the answer is yes to those complexes, you have a sinus complex of some sort. But it might not look like the patient next door's. But the criteria is there. Then you start filtering out all the other little things, like what the heck is that? Okay, but don't get yourself confused and make it harder. Isolate one complex at a time. Don't look at the big thing, one complex at a time. I can't determine that that's a forest of pines if I haven't looked at the individuals first, correct? Okay, we'll look at the individual complex to start with. Do you have a sinus mechanism? So in the first one we have sinus. What do we have in the second one? So if I were to ask myself those same questions I just said of you, do you see upstroke P waves? Yeah, I see a bunch of them. Is there a corresponding QRS for every one of those? What's the answer?
No.
No. I've got many P waves in here with no QRSs responding to them, don't I? So I know it can't be sinus. That ruled that out right away. What I have is an uncoordinated effort between the atria and the ventricle. Ventricle's firing like, well, I don't know which one to respond to, so I'm just going to kind of randomly respond to P here and there, and which results in that irregularity, okay? What is the rate typically when a patient first converts to atrial fib? Rapid, okay? It's typically pretty, we call it with RVR, rapid ventricular response. And that's where our problem lies, not only in the fact that we have an uncoordinated effort, so we're compromising filling, but we also are squirting an empty turkey baster. Remember the turkey baster? If it's not coordinated, if it's not allowing for filling, then what you're putting back out is not filled either. It's like, heart's no different than that. We've got to have a coordinated effort so that volume goes where it's supposed to go, and we've got to have a forceful, complete contraction for it to get out where it's supposed to go. So atrial fib is not at all uncommon post-operatively for the open heart surgery patient, not at all. We kind of expect for it to at some point occur. The heart's been manipulated, it doesn't like it, and this is one of the ways it talks back to us in dysrhythmias. Okay? So, what electrolyte do I monitor related to this? Potassium is important, okay, but potassium really goes towards those ventricular dysrhythmias, but still, I'm going to look at my potassium level. We're going to look at all our MAG level. We're going to look at all the potential electrolytes that could potentially affect my rhythm. Why would I look at a CBC? What is a CBC going to tell me about this? That's right, I'm looking at my H&H here, okay? If I've got a patient that could potentially be having a reduction of cardiac output, will that not potentially reduce oxygenation? Yeah, because if perfusion is lessened, oxygenation is lessened, okay? Please don't get those two elements confused. Can I have adequate cap refill and have a patient who is hypoxic? In other words, can perfusion be okay, but gas not? Yes. Cap refill by itself is not going to tell you if your patient's adequately oxygenated. Cap refill looks at perfusion flow. Okay? Now, does perfusion affect oxygenation? It does. Okay? But make sure you understand we're talking about two physiological different processes here. Think about your COPD, your emphysema patient, not your blue bloater, but your pink puffer. Perfusion is not affected by this process, but gas exchange certainly is. Okay? Because of the dynamics and the pathway behind the disease. So we want to look at we want to look at any value that would have anything randomly to do with the rhythm and or perfusion. So I'm not going to spend a lot of time on this. I talked about cardiac rehab. Why is that different? That's not a test question. Okay? You just need to understand the discipline role there. Cardiac rehab is primarily staffed by registered nurses, and they're not restoring any functional deficits, musculoskeletal wise. They're rehabilitating a very sick heart, which requires that skill and expertise of the RN, knowing how to read rhythms, what physiological response should we have to exercise pre, during, and post. There are some responses. You should have vasodilation after exercise. You should have a drop in pressure. Resting heart rate should return within a very short window of time. You know, these are all the elements that the person that's trained with this would know what to look for, okay? What lifestyle adjustments do you think a person would need to make with any form of cardiovascular disease? Diet, smoking, health habits, in other words, right? Health habits, okay? All right. Now, pacemakers, and again, I know that this gets confusing, so I want to spend some time on it, which is why we stopped the other day so we could pick up today. Do not confuse a pacemaker with an AICD, although they can be implanted in the same device. One device can have both mechanisms of action, but don't confuse what they are doing for my patient. Does anybody in here feel their own pacemaker firing right now? You don't feel a pacemaker fire. When a patient has an artificial pacemaker, they don't feel it either. It's not the same electrical impulse that we do to shock a rhythm. This is a tiny little impulse to initiate that response from the atria through the ventricles. Okay? It's just replacing the action of the sinoatrial node. For whatever reason, that node has failed, or there's some disturbance in the pathways through there to the ventricles, and we need to fix that. The highway got interrupted. Something happened. The bridge blew out. Something happened. It can be the result of a heart attack. You know, if a patient has a heart attack, it affects that part of the heart muscle. Remember, that tissue is no longer viable. It's not going to regenerate. Could it have taken out some of the electrical conduction? Well, yeah. If I bulldoze a wall, isn't that going to take out some of the electrical conduction? If I haven't planned to reroute it, isn't my conduction going to be affected by that? Okay? Muscle wall abnormalities, hypertrophies, etc. Dilated cardiomyopathy. So if there's any alteration in the wall where the electricity is housed, it's going to alter your electrical conduction. So there's times when we have to replace that mechanism with an artificial pacemaker, something that simply either replaces the SA node or works on a lower pathway through the ventricle, because there's a miscommunication between the two. But your patient will never feel that impulse. Whereas an automated internal cardiodefibrillator, they feel that, because it is a shock, and the purpose of that shock was to do what? Stop whatever that underlying rhythm is in an attempt to restore normal conduction. We're slapping the hysterical person. Okay? They do feel that. So I'm going to talk about AICDs for just a minute longer, then we're going to go to temporary pacemakers. AICDs, what kind of patient is going to need an implantable cardiodefibrillator? Say it again. Okay, keep thinking. That's going to be your pacemaker. Who's going to need the one that shocks me? They're a survivor of sudden cardiac death. They've had VFib, pulseless VTAC. Those are your primary people who are going to get this, or people who are at very high risk for that, such as who? Think back to our patients we had in SimLab. Who needs this?
The patient with a
Carly.
heart.
Hypertrophic cardiomyopathy patients. My dilated cardiomyopathy patients, what criteria do we look at with a dilated cardiomyopathy patient and say, okay, this person needs this thing? We talked about something that we measure in terms of how much volume leaves the heart.
If the EF is low,
Who said that? Good job. If the EF is low, specifically what, Chelsea? Below what?
below 50. Or actually, it's 25.
30. 30. Your patient at 30 or below is at high risk for sudden cardiac death. And when we start having those ejection fractions 30 and below, that's what we're going to be starting to fit this patient for. Life vest until we can buy some time to get a ICD. Some of them go straight for an ICD. Those are your people who are at high risk for sudden cardiac death, who have been survivors of sudden cardiac death that wasn't in response to an ischemic event. Like a patient who has a heart attack and goes into VFib, but the ischemic area is reversed after stents or whatever. No, we won't need an ICD for that. That was a response to a situation. Okay, and we fixed the situation, therefore there shouldn't be any more of that response. Okay? So this, an automated implantable defibrillator shocks the patient out of the life-threatening dysrhythmia. Now, who gets that? People who are at risk for that, who have been survivors of that due to hypertrophic cardiomyopathy, dilated cardiomyopathy, or severe ischemic heart disease that we can't fix. They're so ischemic, but there's nothing we can do with these vessels. Okay? Do they feel that? Yes. Nowadays, those devices are so much more sensitive. When they first came out, my first patients with these, they were implanted abdominally, and they were larger devices. And it was scary for them. They couldn't drive. That was it. No more driving, because the devices weren't as sensitive as they were today. So in other words, the patient would start to lose consciousness before the device would kick in and shock the patient. We don't need anybody behind the wheel losing consciousness, right? Right? Y'all agree with me? Okay. However, today the devices are very, very small, subclavian implants, very small. As a matter of fact, there's a microchip out now that they're using. I haven't seen one yet myself. I'd like to. I love stuff like this. But they're small, and they're very sensitive. So often your patient doesn't even lose consciousness before the device is firing. Okay, so they'll tell them, okay, for a little bit of time, we're not going to let you drive. Let's see how you respond to an event. And then they usually will let them drive because they fire so quickly, okay? Which is good, because you think about young people having to work, right? Children to take here and there. I mean, that affects your livelihood, okay? But will they feel it? The answer is yes. Now, your partners to that person are going to have a lot of questions. What happens if I'm with my partner, just a second, if you don't mind, and we're walking in the mall, okay, or whatever, okay? If we're walking, it's my husband and I, we're walking like this, because I'm walking way here. We're walking, okay? He's thinking, oh my gosh, if her thing fires, am I going to feel it? The answer is no. You can touch a patient who has an AICD. You don't have to fear that if that thing fires, that you're going to get hurt. Because the amount of energy required to stop that dysrhythmia when it's directly implanted on the heart is much, much less than it is when we defibrillate on the outside of the body. Now, when we shock somebody on the outside of the body, can you be touching the patient or the bed? No. Okay, the answer is no, unless you want to wake up and say, what happened? Lights went out. Okay? Or find yourself being resuscitated. Okay? That's different because of the energy requirement to do so. All right? So we need to talk to our spouses, partners. There's no need for you to be fearful. You can sleep in the same bed. You can hold hands. You can hug each other. You might feel that person jerk, but you're not going to feel any pain or discomfort. Okay? Real questions that they want to know. Is it scary to walk around with something implanted in you that can shock you at any given moment? Yes. There's a lot of psychological stuff that goes along with this, guys. Okay? That's pretty scary. Okay? And something that takes a lot of talking to your patients. Do we ever put them, I want you to think back to a principle you learned in fundamentals, and you'll be able to answer this question. Would I ever implant a defibrillator and not put them on antiarrhythmics? So go back to fundamentals. Would you ever use adjunct therapies to pain management and not pharmacological? Or is adjunct there to support pharmacological? That's right. So now answer my question. Will we ever put an ICD in a patient and on no antiarrhythmics? No, that's cruel. We're not going to do that. But there are certain antiarrhythmics that have a very, very toxic effects on the body, like which one? You learned about last semester. Amiodarone. Severe pulmonary toxicity, lots of long-term complications associated with it, and yet it's a very effective antiarrhythmic. So it's one of those drugs, no, we can't use it forever, okay? So we have to look at that combination of therapies and what can we use to manage this dysrhythmia, because it's just downright cruel to put someone in an implantable defibrillator and nothing else to manage rhythm, okay? And it does take, they do get scared, okay? But when you talk to your patient and they're scared, I remember this gentleman, Mr. Leon, I loved him to death. Severe dilated cardiomyopathy, really sick gentleman, and he coded one day when my students were on the floor, and I'd had him as a patient years ago, and he said, what would you do? And I said, Mr. Leon, as a nurse, I'm not going to answer that question, but I'm going to tell you that if you were my daddy, I would tell you, why haven't you already gotten this? That was my answer. Because he coded at Walmart in the parking lot. He had no idea what was happening. He was putting his groceries in his trunk, and next thing you knew, he woke up in the ER. And he was so sick, he was so fortunate that he was there. What if he had been out on his county road? Who would have found him, and when would they have found him? When it was way too late. Anoxic brain injury occurs at how many minutes? 3 is when it begins. 4 is you're done, permanent. Long-term hypoxic brain injury effects. That's not a long time when you're out on County Road 54. Okay? So these devices save people's life. Now, switching to a pacemaker. Who needs a pacemaker? We'll get to the little criteria here in a second, but these are just some of the different ways we can pace a patient. And interestingly enough, through most of these devices, we can also shock. For instance, your crash cart, you've got the pads. We can pace or shock through pads. An ACLS nurse will indicate which of the two we're going to be doing. That, remember, ACLS is different than BCLS. The ACLS nurse determines the rhythm and determines what's indicated. Okay? And an ACLS nurse can do either. So we've got through the patch, transcutaneous. Then we have the permanent implantable. And then we have the transvenous, looks like a giant remote control, and they'll either be threaded through wires through the femoral area or through epicardial wires through the chest. But these are actual wires that are implanted on the heart temporarily through a temporary device on the external part of the body. Okay, so who needs these? Well, people with Brady dysrhythmias, like Josh was saying a minute ago, the heart blocks. Not your first degree, not your second degree type 1. Your second degree type 2, and you're complete. Those people need a pacemaker, okay? People who have sick sinus syndrome, in other words, something's going on through there. There's a very bradycardic sinus mechanism, but it is bradycardic. People who have had heart attacks, and it's affecting that part of the heart muscle, like the right atrium, which is where your SA node is housed. And every post-op patient is going to at least have the epicardial wires in place. Whether they've had a valve or a bypass is irrelevant. They're going to have the epicardial pacing wires intact. Okay, so I'll show you some pictures of what that looks like in a minute. So in other words, anybody that has any form of dysrhythmia that would cause the heart rate to get too low, in a nutshell. So that little generator is the little thing I told you. It'll either be your crash cart, or it'll be that little implantable device, or it'll be the little thing that looks like a giant remote control. These are just the things. Don't memorize this. I just want you to understand how we get there. Now this is important though to understand that we can do pace 1 chamber or we can pace 2. That's important to note. We can either pace 1 or we can pace 2. So here's a picture of the epicardial pacing wires I was talking about. Can you see the blue and red wires coming out from the chest? You'll see those? What they do during surgery is they'll implant the wires on the heart muscle where they want them, and then they'll pull them through the chest from the inside out. So they come out through the sternum on the outside of the skin. Y'all follow me? And then they close the chest back up. And then it's connected to your generator, your pulse generator. Okay? I talked about the different types already. All right, important, try not to memorize this, let's just think through it. If you have a device that's a DDD, if you look in the chart that says DDD, what that's telling you is we have two chambers being paced and sensed. Dual chamber device. If you have a VVI, we're working on the ventricle only. That's in a nutshell, paraphrasing everything. Why does this matter to me as a nurse? Because what I'm looking for on my rhythm strip is important. So let's look at this first one up here at the top. First of all, a pacemaker spike has a very distinct look. A straight up and down line. If you see a straight up and down line on your complex, that is a pacer spike. Okay? Behind each straight up and down line, you should have a physiological response. In other words, and I don't know, I'm trying to think of a better way to explain this, but the only one I can think of is like, I don't like them because I love animals, but those cattle prods, do you know what I'm talking about? The little spark at the end of it. If a rancher is trying to get cattle to move from one area to another and the cattle aren't moving, this is some little device that they can do. It doesn't cause any harm to the cow. It hurts my feelings. I don't like it, but whatever. But they can put it on the little hiney ends and the cow will move, okay? But there has to be enough energy coming out of that prod to make the cow move, correct? I mean, if it feels like a horsefly, they're going to swat it with their tail and move on, correct? All right, so think of the pulse generator, the pacemaker, as that cattle prod. It's going to give a little bit of electrical jolt to the heart, not like a shocker, okay, but just enough to start and initiate an electrical response. It's like turning a light switch on. Isn't that going to start an electrical response? That happens, instantaneously, right? Okay, so this is no different. So what you're going to see on your monitor is a straight up and down line. You see the straight up and down line? Y'all see those? That's not, we know that that's not natural. Nobody has a straight up and down line on their physiological mechanism. So I know I got a pacemaker, I want to see that. Whoop, pacer. Now if we look at the top one, are we pacing just the ventricles, just the atria, or both? Both. That's exactly right. That is what we call an AV sequential pacer. It is obviously a DDD, dual chamber. It doesn't always have to do both. It might be that the atria is doing good, it only has to pace the ventricles for a little while, and then all of a sudden you might see both chambers, okay? Whereas if I look at the bottom one, what am I pacing? Ventricles. And remember, when you have ventricular pacing, the QRS is going to look wide and bizarre. Don't let that confuse you. It's not going to look the same because it isn't a natural sequence of events electricity-wise through the heart. So it's going to look different. How would I know at the end of the day that this is working for my patient? What am I going to do? You have a pulse. Because that's what we're trying to achieve. You have a corresponding complex with that. That's resulting in perfusion. Where do you check pulses in an emergency situation? Carotid and why? Why do we check them here? Because if you don't have one here, you certainly aren't going to have one in the periphery, right? But sometimes there's just enough perfusion that we're getting to the core, but we're not getting to the periphery. So if I'm standing here checking a periphery, I might not feel one. But that doesn't mean we need to do compressions because we still have action, okay? But if I'm looking for the physiological response of a device like this, I need it to perfuse everything, right? So I should have peripheral pulses with this because that's what I'm trying to accomplish is adequate perfusion, okay? I need the heart to beat, contract normally, so we have that. So what are the different elements on there? Your provider will determine the rate. Now if it's an ACLS situation, the nurse will say the rate, and usually our standards is 60, okay? But the provider for your permanent devices and your transvenous devices will determine the rate. And usually 50, 60, depends. Sometimes I'll turn them way down to 40 just to allow the patient's intrinsic rhythm. Maybe they have an intrinsic rhythm rate in the 50s. Well, if we have it set at 60, we're never going to see that. So we turn it down so we can see what the intrinsic rhythm's doing. output control. How much electrical current did it take to make that cow move from pin A to pin B? In other words, how much electrical current did it take to result in capture of the myocardium? In other words, did we capture the attention of the heart muscle? Did we see the appropriate contraction for that chamber after the electrical impulse? I'll give you an example in a minute. Pacing threshold. What was the minimum amount of energy it took to result in capture? I always say, guys, you don't want to pass any class in nursing school to 74.5, right? Why not? Why not? What's the statistical issue that we're worried about? Are you going to pass NCLEX? Do you want a pilot flying your plane that passed with 74.5? I don't. I'm just going to be honest with you, I don't. I'm worried. Like, Okay? You want someone that's competent and has exceeded that minimum threshold. I don't want my pacemaker that my body is depending on set at that minimum threshold. We want to go a little bit above that. That way we have what? Room for error. Okay? So they're going to find, what is that minimum threshold? Maybe it was 20 milliamperes. Like, well, you know what? Let's put it at 25. Okay? That's your minimum amount of output. How much energy did it take to get that device? Sensitivity. Like I was saying a minute ago, while I need this device to detect when I need it to fire, I also need it sensitive enough to know when I've been able to do it by myself. When was the heart able to initiate its own electrical impulse? It didn't need the pacemaker. It needs to be able to detect that and stand back and allow that normal, what we call intrinsic rhythm, to work. So I need it sensitive enough to know when I need it, sensitive enough to know when I don't, right? So I need to look at that ability of it to detect that. Don't worry about interval control. That's where they're, and that's set by your provider. How much time are we going to allow between the initiation of the atrial complex and the initiation of the ventricular complex? Okay? That's usually preset, good to go. All right, so what can go wrong? And we'll have some pictures of these in just a minute. Failure to pace. I don't see any straight up and down lines where I should be seeing them now. Failure to pace. The device is either not working or our leads have been pulled out. Failure to capture. On the first strip, first one I'm talking about here, you're not going to see spikes, and you should. On the second one, you're going to see spikes, but you're not going to see an appropriate response from the myocardium. In other words, we just did the little cattle prod to the cow, and it moved and flashed its tail at us, but did not move. It didn't respond. Failure to capture. Here, typically, you're at that minimum threshold or below it, and you need to go up on your output. We need to increase the amount of energy it took to get that attention. Okay, so the difference between 1 and 2, the first one, you're not going to see spikes when you should see them. Number 2, you're going to see spikes, but you're not going to see the myocardium respond to it. Now, these other two are incredibly confusing, and I intentionally, if I put one of these on the test, it will be very plain, okay, because it can get so complicated with this, and I'm not going to do that to you. That's not a pre-licensure requirement. But if we read what it's telling me, over sensing, it thinks it saw something and therefore doesn't do what I need it to do. Whereas here, under sensing, it's not sensing that I did do it. First one, inappropriate, it'll make better, I'm just going to show you pictures in a minute. Okay, pictures say 1,000 words. So let's look at what that looks like. All right, look at number 1. We have a period of nothing going on, right? If I were to check my patient's pulse, do I have one for that period of about 3 seconds there? No, right? There's nothing on there. I have P waves and nothing else. If I've got a pacemaker in this patient, should I not see spikes here with a complex? Because that's what it's supposed to be doing, right? It's supposed to be able to say, hey, you're not beating, so I'm going to make you do it. Correct? That is a failure to pace. Something's wrong with my device, battery's dead, if it's a permanent pacemaker, hopefully don't let it get to that point. Or the leads have been pulled out. It's not pacing. But look at the difference between failure to pace and failure to capture. So here, on the second one, indeed the pacemaker detected a period of bradycardia where it's like, whoa, this heart rate's definitely below my parameters, whatever they were set at, 40, 50, 60. But the heart muscle does not respond. So once again, do I have a pulse there? No. So on that second strip, typically what we would do in an open heart unit is increase the output on our pacemaker, increase the output. And yes, ICU, CVIC nurses, we do that. Because we operate under a set of protocols that enable us to do that. Why is it important that we have a protocol that allows me to do that in that setting? Because my patient, I don't have time to make a ring-a-dingy-dingy right now. Okay? Could we do that on the floor? No. Okay, failure to capture. So y'all see the difference between failure to pace and failure to capture. In the first one, we have either device failure or leads aren't implanted in the myocardium, something's wrong. Second one, the device is functioning. The heart muscle is not responding. Now, let's look at this third and the fourth one. It sees artifact that it thinks is a complex. So it is over-sensing. It's like, oh, you good? And you're like, oh, no, I'm not. That's like the person that's out there in the ocean waving at the lifeguard. The lifeguard says, hey, how you doing? Like, dude, I'm waving, I need your help. Okay, get it? It's over-sensing. Under-sensing, it's not able to detect the intrinsic rhythm, and so it's firing at will. Look here. Pacemaker spike here, appropriate. Is this one appropriate? No, it's on the end of my T wave. Like, what you doing there? I don't need you over there. Is this one appropriate? No, that's getting higher up on my T wave. I'm like, dude, that's not what you find. Appropriate, inappropriate, appropriate. Y'all see where I'm going with this? It's like it can't see the intrinsic rhythm well enough to discern. That's the only language I can use because it's not really looking at it, okay? It's not able to detect intrinsic rhythm, and so fires at will. And if you look at that, the problem with undersensing is you're probably going to put your patient into VTAC. When we hit that T wave just right, it will start VTAC or VFib. That's why cardioversion is so important, that it's timed. Remember, with cardioversion, your patient still has a pulse, right? So where that electrical impulse fires matters, which is why there's often a delay between the time that you push shock and you actually see the shock delivered. It's waiting for the upstroke of an R wave to initiate that. Because if it fires randomly, like on a T wave, it can put your patient into VTAC, VFib, okay? Whereas over here, the oversensing, it's like, I really need a little bit of an impulse there. That was a long delay there, right? Let's say this one's rate set at 70 something, probably at least at 70. But there was a delay there where it didn't spike and it should have. Got everybody okay with that now? Makes better sense when you see it, doesn't it? Everybody okay? If not, tell me. Okay.
Do you mind saying it one more time?
Which one? Oh, okay, so failure to pace. Failure to pace, you have a period of bradycardia, and you know there should have been pacemaker action there. You're looking at this. If I were checking this patient's pulse, I would not feel a pulse for at least 3 seconds there. What should have happened during that interval is the pacemaker should have detected that change in rate, that drop in the rate below what it's set at, and it should have initiated an impulse, and we should have seen an appropriate response from the heart muscle. Okay? Whereas in failure to capture, the pacemaker is working correctly. It is detecting those drops in the heart rate. It is firing appropriately, but the heart muscle isn't contracting in response. Still don't have a pulse though, right? But how we manage them is different. The second one, failure to capture, the other thing that can result in failure to capture is you have a dead heart muscle. you have a vast area of dead muscle. And I don't, this isn't Frankenstein days, guys. You cannot regenerate a dead heart. Okay? If those cells are dead, they are dead, and they're not going to respond. But most likely, you need to increase your output. Okay? And then oversensing, it sees artifact, but thinks that's the rhythm. So therefore, doesn't fire. Undersensing, it doesn't detect the intrinsic rhythm. Usually here you have lead problems. Your leads are not in the right place. And we can't fix that, okay, guys? We're not going to be tampering with that now. That's a cardiologist has to do that. These bottom two require something done with the wires, okay, and the sensitivity setting on the device. All right, so my management of the post-op patient. We talked about preload, afterload, contractility. We're looking at all these different values. I talked about that you have at least 6 drips your patient's going to come back on. Goes to say without continuous EKG monitoring, right? We try to protect the little, okay, have y'all ever changed out a light fixture in your house that was, hardwired, or anything hardwired in your house where you had the little electrical prod sticking out? Did you leave those 2 little wires loosey-goosey and let them go ping, ping, ping? No, what did you put on them? Those little caps. Those caps insulate and protect those pins from other things, correct? Stimulating them, which could cause a fire in your house. Well, we have the same thing. The pins that connect to the device, the looks like a giant remote control, have to be protected. Like I was telling you, the open heart surgery patients will come back with epicardial wires, period, end. Some surgeons will have them automatically connected to the pacemaker on backup. Some will not. That's a surgeon preference. At the end of the day, my job is to protect those pins from microshock. I don't need them touching surfaces that can stimulate a shock that can go to the patient's heart, right? That's not a good day. Okay? So we protect those. That's all we're saying here. Don't memorize all this, just understand that, okay? We use syringe caps, all kinds of things, tape, we just tape them down on the chest firmly. Anytime I have something that was invasive, what am I looking for? Hematoma, infection, that goes without saying. Now, your perm pacer patient, and these new microchip things don't even require this anymore, but we're still teaching this, so we're gonna go with this. Those old-fashioned implantable devices, whether it was an ICD or a pacemaker, you didn't want your patient lifting their arm way up. Why? What was that going to do to the wires implanted on the myocardium? Pull them right on up. They've got to graft into that heart muscle, okay? We monitor the site for hematoma development, infection, that goes without saying, correct? But don't I have some more patient education for them when the patient goes home? How are they going to feel if something goes wrong with the pacemaker? It's not sensing, it's not firing appropriately. How do you think they would feel?
Tired.
Tired. Good job, Andrea. Think about everything that they're going to feel. Fatigue. Everything they would feel if they were bradycardic. Syncope, lightheadedness. How would you feel if you were bradycardic? That's how they're going to feel, because that's what this device is used for, is to manage brady dysrhythmias, right? So if the device isn't working and they're having the brady dysrhythmias, they're going to feel all the effects of a brady dysrhythmia. Okay? Some things are permanent. Now, microwave, when I was a teenager and microwave first came out, y'all, they were huge. They were about as big as our TVs today. Okay? And they were very poorly insulated. So in those days, if you had a pacemaker, you couldn't be anywhere around a microwave. Now they're very insulated. They have the 3 beeps at the end that I know you don't wait for before you take your food out, because I don't. But that's your time to allow all those things to settle down before you open the door. Your pacemaker patient needs to wait for the 3 beeps to stop. Even though they're well insulated today, it's still not advisable for them to stand right over the microwave with the pacemaker right there. What you want your patient to avoid is all strong magnetic fields. We want them to avoid all strong magnetic fields, because what do we use to reset a pacemaker or turn it off? A magnet. Well, nobody needs their microwave resetting their pacemaker. Again, they're well insulated today, and it's not that they can't be around their microwave. They don't have to go in the living room when it's working. They just don't need to be standing hovering over it. Cell phones. They don't need to be carrying their cell phones in the pocket over the device if they have a shirt pocket. And jeans would be better. Arc welding, they can't do that anymore. Okay, arc welding requires a strong magnetic field, and if that was their career choice, they can't do that anymore. Ham radio operation. You'll see these people that still have these big old giant antennas on the back of their vehicle. CB radio days, no more of that. Okay, those require strong magnetic fields. Don't memorize statistics, but remember our goal is to improve cardiac output. Isn't there a goal of any cardiovascular patient? Truly our goal. We're trying to improve cardiac output by either making sure flow goes the way it's supposed to, preventing the consequences that happen when it backs up, right? We're trying to prevent pulmonary edema by promoting cardiac output instead. Our goal of a patient with bradycardia dysrhythmia is increasing cardiac output. Remember that stroke volume times heart rate equation we had? Was it heart rate part of that equation to achieve adequate cardiac output? If we have a heart rate of 30 times my circulating volume, we're not going to have adequate cardiac output, are we? Okay, so that's part of that equation. So this increases cardiac output, and that's what we're looking for at the end of the day. Okay, I was telling you earlier, many people have an implantable device that has both functions. It can do both things. It can shock and or pace. All right. Some of my faves, balloon pumps, and I usually have been lucky enough that about once or twice a semester we have a balloon pump, and I'm like, oh, I love it. And it's so sweet that some of my former students, and some that are not my former students, will come in there and say, can I listen? Please come in. Because it's just a refresher, you know, and I love a nurse that's humble, that admits everybody needs a refresher. I need refreshers, okay? You learn something new every day. And they'll come in there, can I listen to you while you talk to you? Absolutely, because I love these things. They're so cool. Okay, so what is a balloon pump? Let's just talk through it. We're not going to memorize anything. Remember, memory will serve you poorly taking an application-based exam. Now, you have to have that foundation as we go forward. We know that. But I want to focus on what is it doing? How is it working? And when you don't memorize things, it'll make a whole lot more sense, okay? This is truly about the size of those red, cheap hot dogs. You know what I'm talking about? The really good, but really bad for you hot dogs? Y'all know, the red ones. Don't tell me you don't know what I'm talking about. They're really good, and they're so bad for you. Okay, y'all know what I'm talking about. That's about the size of this balloon, okay? It's filled with helium, and we're going to talk about where does it sit, what does it do. Do not try to memorize all this stuff. It's not going to make sense, okay? Instead, let's just think about it for just a minute. At what phase is the heart filling with volume? During diastole or during systole? During diastole is when volume is filling, correct? At what phase is the heart contracting, ejecting blood out of the body, diastole or systole? Systole. Okay, so do you need something obstructing flow during systole? No. So when does it inflate? During diastole. Now you see how we went through that without memorizing it? It makes sense, right? This is how I want you to learn. I want you to learn. And if you just think through a process sometimes, you'll realize, oh, well, I get it. I don't have to read that. It makes perfectly good sense. It can't inflate during systole because then it would just obstruct flow out. So it has to inflate during diastole. Okay? So what is it doing? Before we go any further, I want to talk about how is this going to improve cardiac output. This device is used to augment the left ventricle. What does augment mean? Change or help. We're going to augment the function of the left ventricle. Okay? Isn't it the left ventricle's job to get volume distributed throughout your body? And that's its big role. Okay. So I want you to think about this analogy. What works for me. If it doesn't work for you, you think of another one as you study. Let's say you've only got a short water hose, and I'm trying to water a bush back there by Dina. Okay? I've turned my faucet on. Everybody got my visual so far? I turn my faucet on. I don't need tubing in here, do I? Oh, I did it. Hang on. I'm going to play with this Fuller stuff. Don't tell her. Yeah, this tubing will work just fine. Ignore it. It's not oxygen tubing. That's not what you see. You see a water hose. Okay? It's connected to my faucet over here, and this is the end of my faucet right here. Okay? I've turned it up. and there's volume flowing through here. I'm like, dang, I got to get that bush over there, and this hose is too short. What can I do to increase the amplitude coming out of this end? Kink it. Okay, now while I kink it, while the balloon is inflated during diastole, this is filling, right? Which side's going to have more pressure? This side or this side? This side's going to have much greater pressure than this side, correct? Isn't it true by the laws of physics that things will move from greater pressure to lesser pressure? So when I use that law, I unkink my water hose, what's going to happen to the force here now? It's going to move forcefully from higher pressure to lower pressure, and I might reach Dina momentarily. I got to do it again. Next heartbeat. Kink. Fill. Greater pressure. Let go. Volume comes out. That is how a balloon pump helps volume get out of the left ventricle. The balloon is going to inflate during diastole, which is going to build pressures in the ventricle. When it deflates during systole, it moves from greater pressure to lesser pressure, which is the aorta now. Typically, it's the other way around. The aorta has a high degree of pressure. But this is a weak, floppy ventricle. It can't get that done. It needs that assistance of that momentary build pressure, lesser pressure here. That is how it works to decrease afterload. Isn't it decreasing the resistance to the volume leaving simply by changing which has the greater pressure? Everybody see where I'm going with this? Okay, now, these things are so cool, but there's some complications we're going to talk about. Where does it sit? All that good stuff, okay? I'll put that back in just a second. All right, so where it sits in the aorta is very important. Where it's inserted into the body is very important. It's going to be in the femoral artery. We need a large insertion site. This is a big balloon. It's going to be inserted through a sheath in the femoral artery, right femoral artery. Now, I want you to think about that for a second. If I've got something sitting in the femoral artery, is there anything I'm worried about right here?
Bleeding.
Bleeding is A number one. So I'm going to be monitoring for signs of overt bleeding, meaning I see bleeding on my sterile occlusive dressing, or covert bleeding that I see down below the groin. All of a sudden there's the black area developing or dark hardened area developing on my patient's skin. Like, what's it doing is bleeding through the tissue backwards. Do I need my patient mobilizing this joint?
No.
Absolutely not. Now what if they vomit on themselves? I can't bend this groin, what can I do instead? I can log roll them, okay? But I can't bend this. I'll talk about the patient positioning in just a second. Am I worried about anything that's in an arterial space, whether it's in an arterial space here or an arterial space here? What are you worried about? Arteries go out. What are you worried about? Perfusion. Perfusion where, Andrea? Good job. To the tootsie. Are you checking pedal pulses? Are you looking at the color and the temperature of that foot compared to the other? Because could this have a big clot here? Could it be obstructing distal blood flow? Yeah, and that's not good. We can't have that. That's not normal finding. Despite the fact that I have this device here, I should have pedal pulses. Okay? Just because I have an A line here doesn't mean that I shouldn't have perfusion to the hand, right? It should not be obstructing perfusion. So I'm looking at distal perfusion. Now all that's just related to the fact that I got something sticking in my right femoral artery. It doesn't matter what it is, correct? Okay, now, in terms of the balloon that was threaded through that, does it matter where that balloon is positioned in the body? Absolutely. So we're going to look at our picture here. It should sit above these, which are called what? What do they feed? Renal arteries. It should sit above the renal arteries, but below the aortic arch. That first notch off the aorta. Can you see the picture? See the picture? Now, are you going to be able to look inside your patient and see that it's where it's supposed to be? No. So there's two things I'm going to assess continuously related to the balloon displacement itself. This is not going to have anything to do with balloon displacement. This has to do with something for the fact that you got something sticking in an artery. That's it. But the balloon moving here is not going to have any effect on this, okay? When we're talking about the balloon moving up and down the aorta, there's gonna be a specific effect of that. This is what the device looks like that drives it. A helium tank will sit in here, and this is what it emits this hum when you have a balloon pump. Whatever. Okay. So it's really important for some things to go, and then I'm gonna go into the complications associated. What are you gonna monitor to know if your balloon's been moving? We've got to have a rhythm that's conducive to the function of a balloon pump. If it knows to inflate on diastole and deflate on systole, don't we need a good sinus mechanism? This is really hard to do when we have atrial fib. It's like, okay, I don't know which one of these, when am I supposed to do what? The newer devices are much more sophisticated today and can work with an atrial fib patient, but you have to think about that. It's got to have that mechanism to know when to do what. We talked about inclusion of it with anytime you have something foreign in the body, I've already talked about this. Anytime there's something foreign in your body, what is the inflammatory response going to say? Oh, this isn't supposed to be here. We got to get rid of it. How's it going to try to get rid of it? It's going to clot. It's going to put all these little things around here because it's a normal physiological response. So a clot could get on your blood. Okay. Balloon perforation, you'll know because your line fills back with blood right away, and all of a sudden your patient's cardiac output goes way down. Okay, that's a major complication. Rare, thank goodness. Okay, I'll get to this in just a second. The frequency of the balloon can be timed to where it inflates and deflates on every single electrical, QRS complex, or every other, or every third. So the timing can be a 1-on-1, a 1-on-2, or a 1-on-3. Which of those 3 settings do you think is the weaning mode? Every third. When we're getting to every 3, we're able to wean our patient on. We're seeing how, okay, let's see how cardiac output sustains itself when we're only helping them every 3rd beat. Let's just see how they sustain cardiac output if we're only getting to every 3rd beat. Okay? All right. Talked about this. Now let's talk about this for just a second. Let's go look at our picture as we talk about this. All right. If this balloon were to displace itself and start shifting down the aorta, isn't it going to be occluding over the renal arteries? What is that going to affect? That's right. When a patient is a balloon pump, it is automatic that your urine output's every hour. Urine output assessment every hour. This is where those urometers come in very handy. Do y'all know what I'm talking about when I say urometer? What's a urometer?
It's the thing that hooks on the counter.
It's the hard plastic outside of the bag device. It gives you very specific, concise measurements. Okay? So we're monitoring urine output every hour because we know that one of 2 things has happened. If my urine output starts to drop off, either A, my balloon has displaced itself down too far, or we're still not achieving adequate cardiac output. But in terms of monitoring for displacement over the renal arteries, urine output's my key. But let's look at this first picture up here, this one right here. If the balloon goes up too high over that first notch and is inflating and deflating, obstructing that first notch, what physical assessment finding are you going to find altered? Left radial pulse. The left side. They look at the notch and where it's feeding. Again, you got to go back and know your normal A and P for sure. You're going to find that your left radial pulse either becomes absent or very diminished. Like, whoa, ruggy. Has the balloon displaced itself too high? And that's why those assessments are done every hour and then some. You don't have to wait every hour to check radial pulse. I can do it anytime I get ready to, right? All right. Last thing, then we'll do a quick break and we'll just kind of glean over the peds things. I'm not going over it in detail. We're just going to look at the things I want to make sure you look at. Ventricular assist device. These are also really cool things. I don't see them very often. They kind of buy us some time for transplant. This is a semi-permanent picture here. There are pigtail versions that we do in-house that are very temporary. Like the balloon pump. Can anybody have something sit in their artery for any length of time? No. They're going to be temporary. because there's so many complications associated with the fact that we've got something sticking in the artery itself, right? At some point, they're gonna have to be pulled because of the risk of infection, the risk to tissue damage to the site, the risk to the vessel damage. Okay, there's just too many risks for long term, so after a couple of days or so, they're gonna be looking at, do we need to pull this thing? Okay? This is where your cardiologist, and this happened just, I think last semester, has a discussion with the family. Look, when we stop this, they are not going to survive because this is what's driving their cardiac output right now. And yet we're past the threshold for safe to be able to continue to do this. Okay, and you have those very hard conversations with your family because this heart muscle is not going to work anymore. And they're too acutely ill for a transplant. With this device, for like your dilated cardiomyopathy patients, these are the people who usually get this. What we have is a device that simply mimics the action of the left ventricle. It's like left ventricle, you just go ahead and check out. I'm going to take over for you. If you look at the picture, you can kind of reason through your brain what it's doing. It's siphoning the volume out of the left ventricle, spinning it through a little motor, and going right up the aorta with it. So it pretty much replaces the function of the left ventricle, buying the patient some time for a transplant. The pigtail ones I've seen are like a catheter, kind of like a PA catheter that they put into the left ventricle going from the outside of the body in. Really neat little things because they do the same thing. It's a very small catheter, again about the size of a PA catheter. It siphons the volume up inside the PA catheter through a port. A little tiny, tiny motor on the device itself propels the volume up the aorta, exiting through another port. So really cool things. They can increase cardiac output without having to worry about contractility. Remember what I was telling you about when we increase the force of contraction, what are we doing to the heart muscle's oxygen demands? That's right. And if I've got a really sick ischemic heart, you really kind of got to figure out, okay, what's going to be the better risk here? Just like when we talked about dopamine and dobutamine, I told you this was part of your homework. How do they differ in regards to SVR? Nicole, how do they differ in regards to SVR? What does dopamine do that dobutamine does not? If you can't remember, you can phone a friend. Just phone a friend. And y'all don't pretend like you don't know Nicole when she phones you. Seriously, call somebody. Tyler. Okay, anybody want to phone a friend? Go ahead.
I think I remember.
Okay, go ahead, Brandy.
So the butamine decreases SVR and increases blood pressure.
That is very important. Dopamine increases SVR. Dobutamine decreases SVR. So which of those two do you think is better for my patient with contractility issues? Dobutamine. I need something, because if we increase SVR, aren't we increasing afterload? Okay. Dopamine tends to cause two other potential complications with vital signs that dobutamine doesn't have the same grand effect on. I'm not going to tell you that they don't, but it doesn't tend to do it to that degree. What were they? Blood pressure and heart rate. Dopamine really ramps up that heart rate. Can cause reflexive hypertension. Where dobutamine, while they're both going to increase heart rate, they're both going to increase blood pressure, dobutamine doesn't tend to do it to the same degree. So again, if I've got a sick heart muscle that needs to reserve all the oxygen it can, which is my preference, dobutamine. Dopamine is great when you have a patient who's very hypotensive for other reasons. Now, I'm not going to tell you we don't use them on cardiovascular patients. We do. Okay, we do use dopamine. But your sick hearts, dobutamine is going to be our preference. Okay. Important that you understand how your drugs work. Okay. Really important that you understand what they do, how they affect the patient, and which one of those would I question when I'm taking care of a patient. All right. So going back to this little device, it's helping the heart get that volume out, so for increasing cardiac output without increasing the oxygen demand on the heart muscle. Because anytime I increase rate or increase contractility, I'm increasing the oxygen demand. So again, something else I have to think about as a nurse. How is this going to physiologically affect my patient? There's a therapeutic threshold and then there's a non-therapeutic threshold. Okay? All right, let's take a few minutes to go tinkle, get some Cheetos, whatever. We won't be long at all on this pediatric content. Then I'm gonna give you time for a study group, okay? I think I'm gonna go get my water.